colleagues, and welcome to the ethics component of this year's ECIPA GP Symposium. Today's topic is the impaired GP. So in keeping with the theme of this year's symposium, which is the impact of COVID-19 on general practitioners, one of the things that we as doctors are very aware of is the impact that this pandemic has had on GP mental health. We've certainly been hearing a lot about managing stress, about burnout, about compassion fatigue. And all of this is really because of the importance of avoiding GP impairment. So for today's talk, we're going to follow this outline. We're going to look at what impairment is, followed by the extent of the problem in South Africa, why does impairment occur in GPs, and then we will look at some of the ethical aspects as well as the legal aspects related to managing GP impairment. Finally, we will look at the HPCSA processes that regulate and manage impaired practitioners, and we will conclude with some recommendations. So what is impairment? Impairment in doctors is not a new concept. In fact, way back in 1973, the American Medical Association defined the impaired physician as one who is unable to fulfill professional and personal duties and responsibilities because of psychiatric illness, alcoholism, or drug abuse. The HPCSA in 2020 has expanded that definition. So GP impairment, or indeed impairment in any health professional, is defined as any mental or physical condition which affects the competence, attitude, judgment, or performance of professional acts by a registered practitioner. The extent of the problem is, as one would expect, pretty similar worldwide and pretty much in line with what you would expect in the general population. In other words, doctors are not immune from suffering from the same mental illnesses and addictions that the general population suffers from. The HPCSA annual report for 2020-2021 reported that 389 individual practitioners' cases of impairment were managed. They noted that this is a significant increase in reported cases annually, and that 97% of these were related to mental illness and substance abuse. Salvo suggests that we must be very careful to differentiate between impairment, incompetence, and unethical behavior. And as such, we must point out that these are impairment cases and not GPs being reported for other problems. So Salvo defines the impaired physician as one who is unable to practice medicine with reasonable skill and safety because of these physical or mental illnesses, or for example, substance abuse. In 2016, the HPCSA published some of the stress-related impairments suffered by health professionals in the 2015-2016 year. And unsurprisingly, these match more or less what you would expect as leading problems in the general population. So the commonest cause of GP impairment was psychiatric disorders not otherwise specified, as well as depression, followed by alcohol abuse and opioid abuse, specifically pethidine. So why does this occur? One may almost say that it's an occupational hazard of the profession. We know that doctors work under high stress. GPs have high responsibilities, high expectations, little room for error. GPs work in frustrating working conditions, and our work is time-consuming. This means that there is little time to nurture and maintain family relationships, marital relationships, and time for personal relaxation and recovery from stress. So naturally, these all contribute to the risk factors for GPs becoming impaired. Other factors relate specifically to vulnerabilities related to the physician. And these include personality characteristics. Usually these are the things that lead us into the profession anyway. A high ingrained sense of altruism, of putting somebody else's needs in front of our own. A difficulty in acknowledging susceptibility, that we too are human and that we also need time to recover. And particularly in a profession where you see sometimes distressing situations and have to be responsible for managing them. Certainly, there's a stigma associated with acknowledging that we are impaired, both as our professional competence, but also on a personal level. GPs do suffer from burnout and from compassion fatigue associated with having to see repeatedly the same sorts of traumas and stresses. Another particular vulnerability of doctors is that we have easy access to substances. Many times, substance abuse is related to a specific profession. For example, in anesthetists, easy access to opioids. Sometimes it's related to the nature of the work. For example, the American Medical Association has found that emergency care practitioners would tend to abuse stimulants. Another factor that makes physicians vulnerable is that often these disorders go unrecognized by others. Family and friends would possibly be the first to realize that something is wrong, but it's almost unacknowledged that GPs are susceptible, and people may not want to believe that there is something wrong. Doctors are particularly good at hiding symptoms, particularly of abuse, of substances, and even of mental illness. And then, as Di points out, physicians are a particular group that are different from others in that doctors do not seek help. If they do seek help, it would be more informally from colleagues, or doctors would often want to self-manage their problems. In 2013, the HPCSA published their top 7 stresses that lead to doctor impairment. Unsurprisingly, many of these are related to finances. So financial expectations from family and from society often put pressure on doctors, and we know about this. There's a certain expectation that as a doctor you have to provide for your family, even sometimes for your extended family and your community. There tends to be a high expense lifestyle then that goes with that relative to the income that doctors earn, and doctors tend to get themselves into debt to finance this lifestyle and to keep up these appearances that are expected. As mentioned previously, marital and relationship difficulties often occur as a result of the work-related long hours. Work-related stresses themselves, such as long hours, difficult conditions, working in under-resourced settings, can be a stressor all of their own. And then sometimes doctors have low self-esteem, and this tends to arise out of fears about competence and fears that their training was inadequate, and linked very strongly to fear of failure. And finally, doctors also have medical and mental illness, just like the rest of the population, and this may be unrelated to the career and maybe pre-existing or new onset. So what about the ethical dilemma then that we face? Well, for most of us, we face this dilemma of when we see impairment in ourselves or in our colleagues, protecting the practitioner on the one hand versus protecting the patient on the other. So doctors may be hesitant to report other doctors because we ourselves can relate to the situation that we're in. We may fear consequences for ourselves, stigmatization, perhaps from our colleagues. People don't want to be whistleblowers. But more importantly, we don't want to bring hardship on our colleagues or on our profession. We know that there will be serious implications for colleagues, and that relates to reputation, livelihood and career, financial implications for the practitioner, for their family, and sometimes, as we know, from all these extended relationships. Sometimes there is this fear or this acknowledgement that there, but for the grace of God, go I. We recognize that we all share the same stresses and the same vulnerabilities. On the other hand, we have a strong obligation, and in fact, probably our primary obligation is to protect patients. And whether it is specifically a known patient or the patient population in general, society at large, we have a social contract with society. So how do we decide how to manage this ethical conflict? We go back to our ethical principles. And as you know, the 4 principles are respect for autonomy, beneficence, non-maleficence, and justice. So the 2 principles that primarily come into play here are the principles of beneficence and of justice. The principle of beneficence requires us to prevent or reduce harms and also to act in the best interest. This best interest is in the best interest of our patients, but also can be in the best interest of our colleagues and of society. So really, this blends into the principle of non-maleficence. And these principles require us to weigh up risks and benefits. And doing this risk-benefit analysis, it should be fairly obvious to most of us that the duty to the patient weighs in more heavily. The other principle that comes into play largely here is justice. And as we know, justice deals with fair treatment of others, be it the practitioner or the patient population. Justice, as you know, can be legal justice, rights-based justice, and distributive justice. Particularly here, we're dealing with patients' rights, their rights to effective care, safe care, their right to health care that is not going to endanger them. And of course, justice in accordance with the laws of the country. Another important dimension when it comes to this dilemma of the impaired practitioner is the fiduciary relationship. So fiduciary refers to a relationship of trust, where we have a responsibility or a duty to act in the best interests of another. And in medicine, this fiduciary relationship is between the medical profession and society. And it is up to us to ensure that the public can trust that we as a profession will always act in the best interests of society. And they must have confidence that we are not impaired in our duties, and that if we detect impairment, we will protect society first. What about HPCSA guidelines? So the HPCSA ethical and professional rules, as outlined in booklet 2, which is the guidelines for good practice in the healthcare professions, states very clearly that a student, intern, or practitioner must report impairment of a student, intern, or practitioner that they suspect is impaired. And it's important to note that we talk about students. Studies have shown that in medical students, burnout was recorded in a quarter of senior medical students in a study by Van Rooyen in 2006. And it was also noted that depression is common in medical students and sometimes even extends as far back as the school years. It was also noted that when you look at impaired practitioners, there's often this history of impairment that extends into the student years. And again, this is related to the similar kinds of stresses and vulnerabilities, which we know manifest themselves in the medical school training years and simply just grow and build in the graduate professional. So it becomes very important for us to become aware and to detect impairment from as early on as the medical student years. The other point that the HPCSA booklet makes, and this is an important one, that if we are aware of our own impairment as health professionals, so if we know that there is something wrong, or if we were publicly informed, or if we were seriously advised by a colleague that they think we are impaired or that we should seek help, then we need to actually report this. So as odd as it may sound, self-reporting is recommended. So publicly informed, basically, that's saying that if it was mentioned in front of other people. Another important thing to note is that in their blog, the HPCSA actually says that even the general public may report or even should report. Okay, so how does this reporting occur and what are the laws that apply here? So the relevant law that applies here is the Health Professions Act, number 56 of 1974. So you know by now that we as medical practitioners are governed by many different acts, the National Healthcare Act, the Healthcare Act, Mental Health Care Act, Protection of Personal Information Act. And they all essentially require us to practice in a very professional manner and act in the best interests of patients. But this act, the Health Professions Act, number 56 of 1974, specifically deals with the establishment of the Health Professions Council of South Africa. So this is the act that gives the HPCSA their powers, that outlines what those powers are, what their duties are, and what their obligations are. And in section 15, this provides for the creation of committees that the council may deem necessary. So particularly in point number 5, if they say that if the council decides that they need to have a formal committee, they may do so. And one of these committees is actually the health committee. So the health committee's job is to advise and regulate impaired practitioners. And the HPCSA is very clear in pointing out that the approach is to assist practitioners. It's not a punitive approach. This is very much in line with international norms. So who is this health committee? The health committee is composed of the chairperson of the council, and then 2 psychiatrists and 2 clinical psychologists, an occupational health specialist, and an occupational therapist who has got a postgraduate qualification in vocational rehabilitation. So the reason that there's 2 psychiatrists and 2 psychologists is because one each is appointed from council and the other is appointed by the specific board involved, for example, the medical and dental. Okay, so this act that we mentioned, the Health Professions Act, they point out, what the Health Professions Council may or may not do, and part of this is the committee's role. So the Health Committee's role is twofold. Firstly, they have to deal with policies, or they have to create and implement policies, procedures, and regulations for dealing with impairment. And this is quite specific. It also deals with prevention and alleviation of circumstances that may lead to impaired practitioners. So really, this has big implications for working conditions, for example, or other circumstances, high stress, and all those other risk factors that we mentioned. The committee must also create policies, procedures, and regulations for early identification of impairment, and also policies for handling crises which may threaten patient care. So this is the more immediate situation where the impairment is severe enough to impact immediately the patient's management. And then the second part of the health committee's role, and this is the part that concerns us more today, is that they must investigate and they must manage impairment in health professionals. And generally this occurs either through informal investigations or through formal investigations. And the difference really between these two is that formal investigations is when there is no voluntary cooperation from the person who is allegedly impaired. And then the Act allows for the council to put into place the legal mechanisms and to formally then institute proceedings against this impaired practitioner. Okay, so that's quite a lot to digest at once. And so now let's just walk through the process quite slowly. So as we said, part of our duty is to report an impaired practitioner, be it a colleague or a student or ourselves. So the complaint is then lodged with the HPCSA and the Secretariat. Then at the next meeting, will report it to the Health Committee. The Health Committee then considers this allegation, and they will either decide that, okay, this allegation does not require further investigation and they will throw it out, or they will say, okay, this needs to be informally investigated. So as I pointed out earlier, informal investigation, when the practitioner does not oppose the recommendations by the Health Committee. So what does informal investigation entail? So the council, the Health Committee will say that the practitioner has to be assessed by 2 professionals, one of which will be appointed by the Health Committee, and the other is an assessor of the impaired practitioner's own choosing. So it may be a psychiatrist or it may be an occupational therapist, depending on what the committee recommends. And then there are reports that these specialists have to fill in, and the reports are available on the website. So it's a standard reporting procedure, and there's forms that need to be completed. These then go back to the committee, and they will then make a decision. If they decide that the practitioner is in fact not impaired, then that whole process is it's finalized, and there's no further problem on the practitioner's part. If the committee decides that the practitioner is indeed impaired, then they impose certain conditions on practice. So this is an important thing to point out. Okay, because it does not mean that an impaired practitioner is unfit to practice or that they are suspended straight away. Naturally, the conditions will depend upon the severity of the impairment, but they may range from things like supervised practice or limited ability to prescribe medications, or having to do community service, or practice in a very controlled setting with more direct supervision. And then part of the conditions may be that the practitioner will undergo rehabilitation for whatever the condition may be. Okay, so this rehabilitation process actually takes quite long, and it can take up to 3 years. And this is because there are a number of reports that the practitioner has to submit as part of this process. So in the beginning, in the first year of the process, the committee is required to receive 3 monthly progress reports. And so these progress reports will come from the impaired practitioner and from the supervisor and the treating practitioner who's looking after the impaired practitioner. And once the council is happy that the impaired practitioner is following the rehab process and is complying with treatment, and they're happy with the reports from the treating practitioner and the supervisor, then in the second year, they will only require 6 monthly reports. And again, if they're seeing that the process is being followed, the impaired practitioner is complying with treatment, progress is being noted, then the health committee will only require an annual report in the third year. And then following the third year, the committee will then want to interview the impaired practitioner, and then depending on the outcome, they may either decide to continue imposing conditions for the practitioner to practice, or all conditions may be lifted and the practitioner once again goes back to practicing independently. Okay, so quite a lengthy process, a lot to take in, but the bottom line really is that impairment is not equal to suspension. I think whether you are the impaired practitioner or the colleague who is reporting, this is a very important point to make, that impairment does not automatically mean suspension. What happens if the practitioner refuses to comply? Well, as I mentioned before, this leads to a formal investigation, and the practitioner will then have 30 days to comply with being assessed, or they will then be suspended. Another important point to note is that this whole process comes with important financial implications, because the practitioner has to pay the cost of their assessment of their rehabilitation. If they can't afford it, then they have to seek care from the state. But essentially, it can be quite a burden, because not only is your own ability to practice limited, but there are also some great expenses incurred here. So this brings us to the question of what is the right thing to do. So we have responsibilities at various levels. As an individual practitioner, we have a responsibility to ourselves to prevent impairment. And this includes managing all of those risk factors that we spoke about earlier. So managing our stressful lifestyles, managing to take care of our own mental health and to maintain our own relationships, and seeking treatment when it is appropriate to do so. At the level of our colleagues, our responsibilities include detecting impairment in colleagues, intervening when we detect impairment, and managing impairment. This can be quite problematic because not only, as we mentioned before, are doctors often hesitant, but often it can also be difficult to detect problems in colleagues. We mentioned some of the reasons why this is so. Doctors do become quite skilled at hiding symptoms, and often denial and rationalization are big parts of the problem. And it has been recommended by Lindegg that we should be suspicious when we see certain changes. And this again does not make it easy because these are very subtle changes. So if you notice that a colleague has subtle personality changes, mood swings, outbursts of irritability, if there's paranoia, euphoria, hyperactivity. So in other words, if you're seeing symptoms of intoxication and symptoms of withdrawal. Also on a larger scale, if you're seeing impaired work performance, frequent absenteeism, poor performance or decline in performance, if you're seeing increasing conflict with colleagues and with staff and even with patients, if you're seeing declining hygiene or doctors that are becoming isolated from others, then these are all things that should raise our suspicions. And it's not easy to do, but we do have to offer help or approach colleagues and raise concerns. Interventions can be offering help, recommending and referring to treatment, and eventually it may include reporting impairment. And in fact, as the guidelines point out, that should be as soon as we are aware of it, we should report and then take steps to manage impairment. As a profession, we have a collective responsibility. And so our responsibility at the professional level is to make sure that patient care is optimum and uncompromised. And so necessarily impaired practitioners concern for them and their rights has to take a back seat to concern for patient care. So in conclusion, it may be difficult for us to acknowledge, but the right thing to do is to report impairment in ourselves and in colleagues when we see it, and just to acknowledge that this must be done not with the aim of punishing, but with the aim of supporting. Outcomes have generally been reported to be good, and as high as 85% recovery rates have been reported, with practitioners continuing to practice. So in the long run, you are also benefiting the practitioner by early recognition by management and getting them back into their role. I hope that this talk has been useful for you, and there will be some time for questions thereafter. Thank you.